Thank you for inviting me to speak to you today. I've been a bariatric surgeon for 20 years and performed over 3,000 obesity operations in adults. I now limit my practice only to children and adolescents with severe obesity. In my role as the chief of bariatric surgery at St. Christopher's Children's Hospital in Philadelphia, I'm sometimes asked to evaluate Prader-Willi children that have severe obesity. And in fact, I recently evaluated an 8-year-old child who is already 250 pounds and bound to a wheelchair most of the time because of his obesity. And the parents were asking me whether there was something that could be done for their child surgically, since they had not found anything that was helpful medically. So I find there's a lot of confusion around Prader-Willi syndrome and obesity surgery. And to try to clarify what the literature says, we did this systematic review. And I'm hoping to clarify this and help you to understand a little bit more about the possible role of bariatric surgery in children that have Prader-Willi syndrome. So I have no disclosures. The goals of this study included determining the frequency of postoperative mortality following metabolic and bariatric surgery in individuals with Prader-Willi syndrome, and also, if in fact there was an effective treatment, which operation would be most effective. So as you know, Prader-Willi syndrome is a genetic disorder from the lack of expression of a few genes in the chromosome 15, and it affects about 1 in every 15,000 live births. As a result of that, there is hypothalamic pituitary axis dysfunction that it results in growth hormone deficiency, osteoporosis, hypogonadism, and for the purposes of this presentation, hyperphagia and obesity. Prader-Willi syndrome is also the most frequent genetic cause of life-threatening obesity. So we did a librarian-assisted systematic review of the English literature, and we found 28 articles that reported on the results of individuals with Prader-Willi syndrome that had metabolic and bariatric surgery. And this dated back to 1974. So this is basically all of the literature on this particular subject. We also then did an analysis of this mortality, and we found that there was 103 individuals in this set of patients and that had Prader-Willi syndrome and metabolic and bariatric surgery. And we found 2.9% postoperative mortality. Now that's much smaller than reported in other review articles, and I can explain to you probably why that is. And postoperative mortality, the first thing is postoperative mortality is defined as mortality within the first 12 months after an operation. And so if you talk about all mortality forever, then of course the number is going to be higher. But this usually means that the first 12 months, if there's a mortality, it may be associated with the operation. After that, it's unlikely to be so. We found 3 mortalities, as I mentioned. Back in 1985, there were 2 jejunal ileal bypasses that showed evidence of mortality, with one a pulmonary embolus, the other a perinephric infection. In 1997, there was another mortality reported after a gastric band, and that was a result of GI bleed. Now, to our surprise, we found no postoperative mortality within the first year after the operations that are being done today for obesity. That's a laparoscopic gastric sleeve operation or a biliopancreatic diversion with or without a duodenal switch, or a gastric bypass. There were no mortalities in the first year after those operations. Also, we noted that there was no mortality following the 1997 report, and that was in 71 patients. So that's over 25 years. There has not been a reported case of mortality, post-operative mortality after these operations. So here, this is demonstrated graphically. You can see the first three bars represent the operations that are currently being done today: gastric, laparoscopic gastric sleeve, gastric bypass, and biliopancreatic diversion. You can see other procedures like the gastric band, adjustable gastric band, vertical banded gastroplasty, or jejunal ileal bypass. And all of those are no longer being performed for generally, although occasionally a gastric band may be placed. But all the mortality was in those groups. The other thing to note is that there was one report back in 1975 that reported on 7 Prader-Willi patients that had metabolic and bariatric surgery, but the article did not define which operation was done for which patient or how many operations in each category, so we could not include them in our meta-analysis, but we did include that in our mortality review. So there were 4 recorded deaths years after the bariatric operation, 4 to 9 years after, and you can see them listed here. All of those are not related to the operation, but are related to the severity of obesity getting worse and eventually causing a fatality. So then we turn to doing a meta-analysis of the change in body mass index, and I'll try to get this picture out of the way for a little while. And it's for the change in body mass index. So we used as our inclusion the diagnosis of Prader-Willi syndrome, body mass index equal to or over 35. They had to be primary metabolic bariatric operations, and with a minimum of 12-month follow-up. We excluded patients that had had a previous metabolic and bariatric operation, and also operations that are no longer performed or had so few numbers, or both, so that we couldn't do an analysis of them. And what we found was that there were 67 patients that of the 103 individuals that met criteria for the meta-analysis. So these are those operations I mentioned. I'll bring this picture out of our view a little bit. Here are the 3 operations that are being done today for obesity, and these are the 3 that are in the meta-analysis: gastric sleeve, biliopancreatic diversion, and a gastric bypass. And let me explain how these operations work a little bit. So a gastric sleeve operation, you create a tube or a sleeve out of the stomach along the lesser curvature, and the rest of the stomach is removed. All these are done laparoscopically with minimally invasive techniques today. That lighter portion of the stomach in that left panel then would be removed, and that removes a lot of the ghrelin-producing portion of the stomach so that the ghrelin hormone goes down. They don't have hunger and a cycle for breakfast, lunch, and dinner any longer, and that contributes to their weight loss. Also, the small stomach contributes to their weight loss, but also because of the smaller stomach, the sleeve empties more rapidly, and as a result of that, gastrointestinal receptors are triggered so that GLP-1 is produced, which decreases in the hypothalamus and in the rest of the brain. It decreases the cravings over food, and also decreases their interest in food, and it also decreases their appetite. Also, another hormone is released, and that's PYY, and that helps them to feel full or satiated earlier. So all of those work together to create significant weight loss after gastric sleeve. The middle panel describes a biliopancreatic diversion with duodenal switch, and what you can see is that it looks like a gastric sleeve, but the food that goes into the gastric sleeve will no longer go directly into the duodenum and all the way through the 24-foot of small intestine, but rather it goes through only 250 centimeters of small intestine. There is no small intestine removed, but that means that this is calibrated so that they would only absorb about 1,500 calories a day. And this is important because as we go on with our discussion, you'll notice that this particular operation has weight loss that continues longer, and there's less obesity recurrence. A gastric bypass really functions very similar to a gastric sleeve and has been around since 1967. And you see there's only a small number of Prader Willi patients that had this particular operation, just 10 patients. So here is the data. And of course, I won't bore you with all of the details here, but there are a few things that you should be aware of. The first thing is, in highlighted in yellow, is there is a difference, a statistically significant difference in age in the gastric sleeve patients compared to the other patients. And that's because these patients are from Saudi Arabia, and Dr. Al-Qahtani did operations on younger children in Saudi Arabia, and that's part of this meta-analysis. But these operations were successful, and the patients generally did well. Now, the other thing that I wanted to mention to you is that we used as a p-value 0.005 for statistical significance, and you can see that we were able to obtain that with all of the patients for the first year after surgery, comparing the baseline preoperative weight and BMI to the 1-year BMI. And that continued for gastric sleeve for three years, and then we could no longer show statistical significance. And with the biliopancreatic diversion, the BPD, we were able to show this out to 7 years with statistical significance. And the gastric bypass patients listed here in the OAGB, RYGB, those patients had significant weight loss for the first year, and it was statistically significant for 2 years. But after that, we could no longer show statistical significance, and part of that is because the numbers were just so low. So this is the same thing being shown, and if you look at the gray line at the upper line, you notice that that is the biliopancreatic diversion line, and it starts at a higher BMI, but the amount of weight loss is about the same in all three of the operations in the first year from their baseline. And you can see that that continues all the way across the graph and is statistically significant out at 7 years. By the time you get to 10 years, there are not enough patients to show statistical significance. The dotted line is the gastric sleeve line, and you can see that the BMI stays down through the third year, but then increases after that. And the dotted line is the gastric bypass line, and although it looks like it stays for 3 years, there's no statistical significance in that third year because the number of patients is so low. So how does that compare to patients that do not have Prader-Willi syndrome? Well, it actually compares very well in the short term, and you can see under the PWS list line, they lost significant amount of weight for the first year, and that compares very favorably to patients that do not have Prader-Willi syndrome that are in the national database that we all send our data to in the American College of Surgeons. Also, just notice the overall 1 year weight change in BMI was 14.7. Of course, there are a lot of limitations to this. There aren't very many numbers. There was enough to show statistical significance and do a meta-analysis, but these are small numbers, inadequate long-term follow-up, and part of that's because there is not a registry to register these patients into at this time. And it is also limiting to have inconsistent reporting of comorbidities and resolution of comorbidities. And there was age and ethnicity discrepancy in these different subsets as well. So my conclusions are that postoperative mortality in Prader-Willi patients, reviewing the literature, is 2.9%. There is no reported postoperative mortality in any patients that have had been reported to have had a gastric sleeve, a gastric bypass, or a biliopancreatic diversion. The average reduction at 1 year was 14.7. BMI points, which is similar to about 100 pounds in a person that is 5'5", and also also 45 kilograms. Statistically significant BMI reduction, however, was sustained in the gastric sleeve patients for 3 years, gastric bypass patients for 2 years, and we can show statistical significance for reduction in BMI in the BPD and BPD-DS patients for 7 years. So with those conclusions, I think maybe we do have a solution that might be helpful to that 8-year-old child that's really struggling tremendously with sleep apnea and other comorbidities. And I would say that really there should be consideration of metabolic and bariatric surgery in Prader-Willi patients, and that should not be withheld from them. So with that, I'm happy to take questions, and thank you so much for your attention.